Dr. Pankaj Gupta sir. He is a national coordinator of ISA. He is a private practitioner working in Nashik since 34 years. He is very much interested in the upliftment of our profession. Our next chairperson for the session is Dr. Nanda Nadyal Madam. She is professor at Mahadevappa Raipur Medical College. Madam, please. I request the third chairperson for the session, Dr. Vinayak Patil sir. Sir is a senior freelancing consultant anesthesia. His area of interest is pediatric and cardiac and regional anesthesia. He is the GC member ISA. Now I request Dr. Balaji Asegaonkar sir. He will give us insights to one of an interesting topic, a management of 50-year-old patient with permanent pacemaker posted for TURP. I request our chairpersons to please introduce our speaker.
Good afternoon, dear friends, for the post-lunch session. I know we have had a very heavy lunch and the hospitality of MIRAJ-SANGLI has been fantastic. Dr. Balaji Asegaonkar requires no introduction to the city of Maharashtra. He is a cardiac anesthetist, does a lot of palliative care, well known for his geriatric medicine, and above all that, he is a wonderful human being. He just finished his 1 year as a president of Maharashtra State ISA, SAMS that is now called. Along with his academic, he is well known for his great original ideas of having group practice, and also he is very socially inclined and runs a wonderful center in Aurangabad. Over to you, Dr. Balaji.
Good afternoon, everyone. Those who are eating, I request them to do it leisurely. Don't take stress of my topic. And those who have finished can attend my lecture. Respected chairperson, thank you for my kind introduction. The topic on which today I am going to talk is anesthesia management for patient with a permanent pacemaker. Before I start, greeting from Ozone Anesthesia Group. We are doing group practice at Aurangabad, and we have a 32 consultant who are working in Ozone Anesthesia Group. We have our Ozone Learning Academy YouTube channel, and you can find number of useful topics on that. And this is our group. And every Wednesday we have a online academic activity at 8 a.m. in the morning. And all those lectures are uploaded on YouTube, and very interesting and useful source. You can use it for your own benefits. Now, as far as today's topic is concerned, why I am showing you these slides? These are the wonders in the world, Taj Mahal or Great Wall of China or this Pyramid of Giza. Now, are there any wonders happened in medicine? And yes, these are the three important discoveries, you can say, or inventions. They have changed the practice of medicine in last century. In the sense that due to their invention, the maximum people are benefited, and it's a big boost to the mankind. Intubation, rehydration therapy, and last is the pacemaker, and we are going to talk on one of them, that is pacemaker. And it's, if patient is having a pacemaker, how to give anesthesia or what precautions we should take. So the objective of my talk is to review basic pacemaker terminologies, functions, whatever required for an anesthesiologist, how to evaluate that patient when patient is having a pacemaker, and some discuss about the intraoperative management strategies. Basically, pacemaker is nothing but it provides electric stimulus to cause cardiac contraction when it is not functioning properly, when heart is at bradycardia, or if it is not giving proper rhythm, pacemaker try to regularize this. And not only that, pacemaker also senses the heart activity, means pacemaker senses and then delivers. So this both function can be done by a pacemaker. Now how this pacemaker evolved over a time? There was one scientist, Wilson, who was trying to record the heartbeat, and accidentally he put some resistor in his circuit, and for momentarily that current interrupted. Now he thought that can this interrupted current, if current is coming in pulses, can you use this current to stimulate the heart? So he tried to synchronize this interruption to a heart rhythm level, heart rate rhythm, and this is how the concept of pacemaker generated. It was a very big when it initially invented, but later on refinement occurred, and now we are in an era, recently in 2016, we got a leadless pacemaker. Means just it is like a small AAA battery size. It has to be inserted into the heart, and we are, very soon we will have a batteryless device which will charge with the heart rhythm itself. So this is the journey of pacemaker that has happened over a period of time. Now pacemaker has got a three component. One is pulse generator, this, then electronic circuit, and lead system. This is the lead. So these are the three components of the pacemaker. Now what are the types of pacing? There are three types of pacing. One that is commonly used is transvenous pacing, where we put through transvenous approach lead into the atrium or ventricle. This is the commonest way by which we do. During cardiac surgery, we put a epicardial pacing, mean directly pacemaker electrodes put over the heart, that is epicardial pacing. And another very important type of pacing that is available nowadays is transcutaneous pacing. Suppose patient suddenly had a bradycardia, he don't have a IV access, and this severe bradycardia, patient goes in a convulsions. Even you cannot take IV access. Now what to do in such situation? If you have got a transcutaneous pads, you just attach the transcutaneous pad to the defibrillator, and it has got a specific cord, and if you stimulate the heart with this transcutaneous method, it acts as a transcutaneous way of pacing, and it is very useful in emergency. Now what are the indications for pacemaker? One is a bradycardia support. This is commonest indicator that we know. Then cardiac resynchronization, when there is a dilated cardiomyopathy, ejection fraction is 20%, 15%, and when you want to synchronize cardiac contraction, again you can use the pacing. Third is the intracardiac defibrillator. If suddenly patient has got a VT, pacemaker can sense that and shock that. That is also one of the indications of pacemaker. And nowadays, due to advancement of science, pacemaker can sense the rhythm, sense the demand of the patient, and we make this pacemaker rate sensitive. Like this fellow is saying that feel my pacemaker if you don't believe, means if demand is required, pacemaker can increase the heart rate, and for this we put the pacemaker. How it is inserted? This is a pulse generator, these are the leads, and these are the placement of lead tip from which it is stimulated, heart is stimulated. Now pulse generator is usually placed subcutaneously. If patient having a pulse meter, if you just palpate this area or epigastric area, you can feel that pulse generation. And usually a lithium iodide battery, and it lasts for 10 years. As anesthesiologist, we must know this. Why, I will tell you in my subsequent pre-op evaluation. Now electronic circuit has got two important aspects. One is sensing the intrinsic rhythm of the heart and stimulating the heart. So electronic circuit is doing two work simultaneously. Now international societies of North American Society of Electrophysiology or British Society has standardized the nomenclature of pacemaker, and how it is said, when the first letter in any pacemaker is the chamber paced, second letter is chamber sensed, and third rater is mode of the response, whether it is inhibitory or a stimulatory. When patient has got a VVI type of pacemaker, means chamber is paced is ventricle, chamber sense is also ventricle, and response is inhibitory. Now these are the two sophisticated functions that later on added. One is anti-tachycardia or anti-arrhythmic function, and programmable function or rate modulation function, but that I am not going to talk in details. This is how what I told. First is just simply remember PSR. PSR is simple to remember. Chamber pace, chamber sense, and the response. Now, how this lead system is placed? It is placed through central axis, and we have got a bipolar leads or unipolar leads. These are the two leads available inside. I will not go in too much details of this. Now, these are the types of devices right now we are using. Commonest we are using is a permanent pacemaker, and most of the patients for anesthesia, they come with a permanent pacemaker. But these two types are also now are coming to us to give anesthesia. One is artificial implanted cardioverter defibrillator. Those patients who go suddenly into ventricular tachycardia, ventricular fibrillation, and if we can put this type of pacemaker, then they are automatically shock this kind of rhythm, and they are very, very useful kind of pacemaker in this scenario. And third is cardiac resynchronization therapy. For all dilated cardiomyopathy, we are putting this type of pacemakers, and we can also incorporate shock treatment into that, and what we call it as a CRTD, cardio resynchronization therapy with defibrillator. These are the prototype of that. Now, why we want to know as an anesthesiologist, it so much detailed we want to know about this pacemaker, because we want to anesthetize this patient, and our during cautery and all those things, pacemaker can interfere during anesthesia. That is why this theory is needed. Now suppose there is one patient of TURP, 50-year-old, now come for us with a pacemaker. Now how I will evaluate this patient? I will first ask, or I will first try to find out why patient needed the pacemaker. What was the indication of pacemaker, and what was the set heart rate? Now how to see this? The patient usually carry one discharge card or some papers from pacemaker company, and usually it is mentioned on that. Another thing is, as when we are putting a pacemaker, we want that battery to last longer. So we put a pacemaker which will act when it is required on a SOS basis. So whether patient depends on that pacemaker or not, that we have to find out. Now how to find out? If in a whole day, if he is using for more than 40% of the time using pacemaker for the rhythm, it is called as pacemaker dependent. Means even for a minute, if this pacemaker function affects, patient can land into a trouble. That is very, very important point, and as an anesthesiologist, we must look for this. Then whether patient is put on a fixed or demand pacing. What is fixed pacing? Irrespective of the heart rate, patient will be paced. This is a fixed pacing. If required on SOS basis, patient is paced, it is a demand pacing. Now, where is the location of that pulse generator? As an anesthesiologist, you must see in pre-op. I will tell why. Then type and make of the pacemaker. Then time of insertion, because this battery lasts for 8 to 10 years. And suppose this patient received a pacemaker 10 years back, probably this battery might not work, or probably it is downward. It is exhausting. So as an anesthesiologist, we must know this, and you all get this through detailed old papers company, or you can even consult a cardiologist for that. One is we evaluate the pacemaker. Now another thing is important is to evaluate the patient, and invariably this pacemaker has got so many comorbidities. Suppose there is a patient of pacemaker, 50% of the chance that patient will have coronary artery disease, 20 to 30% chance that patient will have hypertension, diabetes. So we have to evaluate other his comorbidities also. Whether a patient is in failure, whether a patient is complaining of dizziness, syncope, this can indicate a pacemaker dysfunction. So we need a cardiac evaluation before that. So we have to evaluate this patient on this all aspects. Specifically, see the heart rate mentioned on paper and do the basic routine, ECG, X-ray and all these things. Now as far as ECG is concerned, if you see this spike, this is a pacemaker spike and you can see. And what are the two spike in this ECG? It is a sequential pacing, means first our atrium is contracted, then ventricular, and both are sequentially paced. These are the two spikes that are shown in ECG. So you must see ECG properly. Then always take a high penetrated view X-ray. Why high penetrated view? When you call it as high penetration, when you able to see the vertebrae through the X-ray, it is a high penetration. Why it is required? Because we want to check the integrity of this lead. This is very, very important, and that is why we need such kind of view. Now with X-ray also we can find out, probably we can find out which type of pacemaker patient has received. This is simple AV sequential pacing. The two leads, one is atrial, one is ventricular. These are the shockable leads that have been put, means it is a defibrillator incorporated into it. If you see, there are three leads. This is a cardiac resynchronization therapy or CRTD. So with X-ray we can find out so many things. Now as far as anesthesia management is concerned, once you evaluated these patients, always always do such cases at tertiary care center, where there is a availability of pacing in case of emergency, where there is availability of cath lab, or even if cath lab is not there, good CIAM is also there, this can also, but pacing facility must be there. Always monitor ECG, saturation and NIBP of all these patients, and in all high risk patients it is preferable to use an invasive arterial line or plethysmograph. Why we want arterial line or plethysmograph? Because we want to monitor the mechanical function of the heart. Electrical function we are monitoring with ECG, but actual contractile function of the heart is monitoring with either arterial line or plethysmograph. See on which ECG, put ECG, there are so many ECG monitors, if you put them on pacing mode, they will show us a white color dot or a pacing rhythm on the ECG. Always keep defibrillator ready. Whenever you are doing pacemaker case, never ever compromise, because anytime if patient lands into defibrillation, which is very common, defibrillator always be kept ready, and always be ready with external transcutaneous pacing or a transvenous pacing. It's not very difficult, even if you have a central axis, and if you are ready with the transvenous pacing, it's very easy to pace. Just you have to put and start the pacing. Now during intraoperative period, as I already mentioned, always monitoring the electrical and mechanical function of the heart. Electrical function will be shown by ECG, but the contractile function, whether there is a actual cardiac output is occurring or contractility is occurring and cardiac output is generated, that has to be monitored. That is to be monitored by arterial line, arterial waveform or plethysmograph. Should we insert CVP or PA in a pacemaker patient? You can insert, but it is always very risky, because your path of putting guide wire, putting central line can disturb the pacing lead. So you should be extremely careful when you want to insert CVP or PA in such these patients. Anesthesia agents, as such, they don't require too much of alteration, but remember that if sensing function of the pacemaker is on, and if at all there occurs, if you give scoline, any fasciculation, or if you generate myopotential, it may change the sensing function of the pacemaker. So you must be, or even suppose you have given a ketamine and myoclonic jerk started, that sensing function is affected. So you that sensing function you must make off whenever you are giving anesthesia to the such patients. Patient when on a pacing, he naturally is not, tachycardia will not occur. So compensatory mechanisms you may not able to find out. So you must remember that these patients will not respond with a tachycardia, because we are already paced these patients. I already mentioned about transvenous pacing, and defibrillator must be kept ready. Then vigorous mechanical ventilation too much of, if you're ventilating patient with too much of tidal volume, there are chances that these leads may get dislodged. Try to avoid shivering. Now, nowadays, suppose no cardiologist is available, and even that person who, from pacemaker company is also not available, and you want to do a case in emergency, and suppose patient pacemaker has got a sensing function. Can you abolish this function? Yes, with the use of magnet. Recently, I have done one case at night. The patient was on a pacemaker with that sensing function on, and cardiologist was also not available. We just put a magnet on that pacemaker. As soon as you put the magnet, it goes in a fixed mode, fixed kind of pacing. So, and then you can do the case, you can use the cautery. So, always rate responsive modes has to be deactivated. Now, there are factors that affect the pacing threshold, but I will not go in details of that. Acidosis, all these factors can affect pacing threshold. I will not give. Now, we are all concerned about the cautery and the pacemaker. Pacemaker is always sensitive to the direct and indirect electromechanical interference. Nowadays, there are MRI compatible pacemakers are available from Medtronics, that is Acusure, Azure kind of, and these are, if they are there, you can do even a MRI of these patients. But otherwise, whenever such patient goes in MRI, it has got so much of chances of complications, because all these leads are mechanical, that MRI has got a very high magnetic interference, and even that lead can damage, even that pacemaker go haywire, there can be a ventricular arrhythmia. So it is strictly contraindicated when patient is not MRI compatible. Then as far as electrocautery is concerned, always use a bipolar cautery as much as possible, because circuit is completed at that point only. If you want to use a unipolar cautery, ground plate should be close to the operative field. Suppose we want to do a TURP, ground plate will be kept below the buttock. Now, this is most important takeaway of my talk, that is always put pacemaker on asynchronous mode whenever you want to do this case. What is mean by asynchronous mode? Irrespective of heart rhythm, irrespective of whatever sensing this pacemaker sense, it will pace at a fixed rate. When you put patient on a asynchronous mode, even if you use cautery, there won't be any interference, there won't be any difference. So always put patient on a asynchronous mode, and always remember, when you finish the surgery, always take this patient on a synchronous mode or a sensing mode. This is very, very important. If you are keep this patient is on a asynchronous mode, and if you want at all use cautery for maybe for very small procedures, very small short breasted for can be used, but try to avoid that all this. Now, measures to minimize the cautery effect. When sensing function is all, whatever I am saying, this is when sensing function is all, always keep pacemaker plate more than away from 15 centimeter away. Always keep temporary pacemaker ready, because so many times this pacemaker dysfunction can occur during the perioperative period. There are certain drugs like isoprenaline, atropine or adrenaline infusions you can give to this patient to increase the basic ventricular heart rate. Isoprenaline is one of the beta 1, beta 2 stimulant, as you know about this. And always recheck the function of the pacemaker in the post-op period. Always take 12 lead ECG in a post-op period. As far as TURP case is concerned, bipolar cause the least interference. Then coagulation current also has got a minimal effect, but if you are using a cutting current at a very high frequency, it can alter the demand pacing. For that, always put patient on a asynchronous mode. This is a very simple things that you should do. So the take home message from my talk is evaluate the patient as well as pacemaker in the details. Put pacemaker on a asynchronous mode and disable all anti-tachycardia function. Always monitor effective cardiac output and keep contingency plan ready in the form of transvenous pacing or transcutaneous pacing. To all my respected anesthesiologists, I always feel that anesthesiologist is a pacemaker of operation theatre. as he synchronizes all asynchronous patient, surgeon and OT conditions. Thank you very much.
Thank you, sir, for your grateful insight to us.
Thank you, Dr. Asegaonkar sir, for your excellent presentation and very basic and updated information about the pacemaker. Sir, just give some highlights to our students about how to use the defibrillator if required, where the padding should be kept, pad should be kept in, if the defibrillation is required in the patients having pacemaker.
Yes, madam. If patient has got a pacemaker on the right upper chest, you have to at least 10 to 15 centimeter away from this. You can keep the one pad, and on the lower side you can keep the other pad. Otherwise, you can keep it on back. Its distance should be more. That is more important.
Thank you, sir.
Now, excellent presentation, sir. Now, I conclude this and request all the delegates ask questions afterwards.
Thank you, Dr. Balaji. As always, an excellent presentation. I really like the last slide of yours, which is actually should be a real take-home message for all of us. And of course, I request questions from the audience, please.
Sir, one question, please. Can we use magnet irrespective of type of pacemaker? And I think it's better to call cardiologist at hand if something goes wrong, because we are in doing many things. So better to have a cardiologist who has inserted the pacemaker if it is in that city only. So my first question is, irrespective of pacemaker, can we use magnet?
No, sir. If patient is put on asynchronous mode by the company fellow, there is no need to use magnet.
How to know that? Whether it is in asynchronous or synchronous?
It is given
In the literature.
In patient who is working or who is talking to you, his pacemaker is never on asynchronous mode. Why? Because whenever patient's pacemaker is on asynchronous mode, it's a battery draining mode. So always it is on a non-asynchronous mode. So we have to, for practically, we have to consider that it is not on it is on a sensing mode, because we want to preserve his battery for a longer duration. And it's a very, if in emergency I am told you to use the magnet, otherwise it is not routinely recommended to use the magnet.
Okay.
If a patient is there for emergency, for suppose for emergency LSCS, and no company person is available at that time, so what should be our policy, or how can we proceed to put the magnet or to make it on asynchronous mode?
Yes, madam. First of all, even if it is emergency, patient invariably has got a papers, discharge papers and details of the pacemaker. Just go through that first thing. Secondly, whichever mode, suppose patient's pacing is on VVI mode or DDD mode, means both chambers are paced, both sense and it is pacing. Just if you have got any query, just discuss it with either cardiologist or a cardiac anesthetist. Thirdly, in that case, you have to take even a simple magnet and put 12 lead ECG and took first 12 lead ECG and then put a magnet on that. It will automatically start the read circuit, what we call it as the internal circuit of the pacemaker, and that sensing function is lost. So it goes in a asynchronous mode of function, and once patient goes in asynchronous function, you can give the anesthesia. But the only thing is that if at all that magnet get dislodged from that point and suddenly cautery is used, we don't know at this point of time whether patient has got again that sensory mode or not, or if at all it can go in some abnormal mode also. So you have to continuously keep the magnet. That is very important.
And keep watch on that.
Yes.
Okay.
For the sake of the students, I feel I would like to ask you.
Yes, yes. Discharge card is always there.
For the sake of the students, I would like to ask you a question, sir. Is the mode of anesthesia and the type of pacemaker has any relevance to each other?
Modern anesthesia?
The mode of anesthesia and the pacemaker, is there any correlation between this type of pacemaker should be given only regional, this type of pacemaker should be given only GA?
No,
Any
sir.
correlation?
No.
So this is one important thing I would like to give a message to all the students here, that there is no correlation whether you give spinal, whether you give GA. Of course, it will depend on in case ejection fraction is low, then you have to be a little careful. But otherwise, the mode of this is a very common question in private. Pacemaker patients on pacemakers who give GA.
Yes.
So there is no such relevance.
Sir, may I
Yes.
ask one? Sir, may I ask one?
Due to time shortage, we would like to
Fine.
restrict the questions. I am sure you can meet sir later and
Sure,
ask
sure.
your question. Thank
Sujata
you.
can ask me question at Aurangabad also.
Now I request Chairperson to felicitate Dr. Balaji Asegaonkar, sir. Now I request Dr. Divanmal sir to felicitate our chairpersons to the felicitation point.